who might join us as we go along. So good afternoon, everyone, and welcome to the June Treatment Committee meeting. Thank you all for joining us today. We have a fairly focused meeting this afternoon as we continue development of the provider landscape assessment. Last month, we generated a substantial number of questions and themes, and today we'll begin narrowing those down and identifying what information is most important for this committee to gather from providers. Before we get started, a quick note, if you would like to make a public comment, please send Ashley a direct message or note it in the chat. We have some time reserved at the end of the meeting for public comment. So Ashley, will you do roll call, please?
Yep, not a problem. Can everybody hear me okay?
Yes.
Okay, great. Katie, you're obviously here.
Yeah, I'm here.
Bradley, is Bradley here? Okay, Moxie, Christy,
I'm here.
thank you. Heather,
I'm here. Thank you.
Clara Wigmaiden.
I'm here.
Great, thank you. Fernando, Amy Nordstrom, Art Mudio.
Present.
Great, thank you. Is Allison here yet? Allison Noyce, okay. Katrin,
I'm here.
thank you. And Lisa, are you here yet? She might be running in a little late. Okay, and then Beth.
Yeah, I'm here. Thanks.
Did I miss anybody? Anybody trickle in while I was? And we have not reached quorum.
Oh.
Back to you. Thanks, Katie.
Thank you. Thanks, Ashley. My next question was if we have quorum, but so thank you for that segue. All right, so I'll turn it over to Director Dahl for updates.
Thanks, Katie. Annalise Dolph with the Alcohol and Drug Policy Commission. Ironic that Allison and Lisa have not joined yet. So I was going to start by calling them out and remind people, if you are not subscribed to our newsletter, please subscribe. The last newsletter from last week featured an interview that Mitch did with both Allison and Lisa, talking about your work and implementing the plan and their history. And it was a really nice piece. So just want to give them a little shout out and appreciation for doing that. What else do we have going on? So OYA meets this evening, the Oregon Youth Addiction Alliance, and they are going to recount, I guess it's not this evening, later this afternoon. OYA is going to go through the past 6 months and do a little celebration of what they have accomplished so far. They have also been working with the recovery committee to kind of outline guidelines of best practices for recovery community centers that serve youth. So that's been really important work. The Health and Safety Interventions Committee, I will note they have switched to the last Tuesday of the month instead of the 4th, and it affects just a few months. This is one of them. So they'll meet at the very end of June to continue their conversations on everything naloxone. They've spent some time talking about expired naloxone and soon to expire naloxone and things that we can put in place to make sure that that is used and redistributed efficiently. The prevention committee is meeting, I think it's the week after next, to continue their conversation about a primary prevention center for excellence, and continue to get updates on the House Bill 3321 primary prevention assessment work. And then recovery, I think they are spending one more month this month talking about recovery community centers. They've defined recovery community centers and put into place guidelines if state agencies are going to fund recovery community centers, what that should look like. And they're working on data and metrics that should be collected now. And that is it for committee work. Settlement board, my only update there is we are working on putting together, OHA is working on putting together the request for grant applications. The expectation is that that will come out this fall. So it will be one round of one-time funding. It is only $13 million total. I don't want to say only 13 million, but compared to the 90 million that we put out last biennium, it's a pretty small amount. So more to come on that. And we'll also remind folks that the local opioid settlement collaborative continues to meet monthly and is a good kind of collaboration with local settlement. That is all of my updates. Let me know if you have any questions. And thank you, Heather, so much for saying those kind words about the newsletter. Most of you, I think, realize that our communications staff person, Stephanie Condon, who has kind of put all that together on the website, is out on parental leave. We miss her terribly. And we work very hard to keep everything going while she is gone. And having Ashley has been so much help. I think we have 2 more months until Stephanie comes back.
Stephanie set you on the right track. It looks great. It's a really nice look. I look at a lot of newsletters, and it's a very informative and attractive and easy to read. Win, win, win. Looks great. I did have a question, Annalise, for you, and I don't know the answer. I was thinking about it when I was going through all of the homework for today. There's so many in the plan. There's so many rules that are coming out for behavioral health, like every month, it feels like, almost probably. And I know you guys no one has the bandwidth they'd like to have. But is there a way that that's kind of coming to the commissioners or subcommittees, or because it seems like, especially with the treatment, our treatment plan, that there's a lot of, because it's an implementation plan, that there would be some intersect there. So that's kind of a broad question. I don't know. You may or may not be able to answer that today, but thanks.
Mitch, do you want us to kick us off, or do you want to just answer?
You can go ahead. Go ahead.
So great question. Overarching, the answer is kind of just like yes, but it is it depends. So when we changed the statute last year, we did require that agencies start to give us notice of rulemaking. I think folks are probably familiar the way we do rulemaking here. It's been a little hard to kind of figure out in advance what's coming. Heather is familiar. Recently, OHA had a community engagement for rulemaking that then went straight to a notice for proposed rulemaking. And the procedures we had put into place with OHA and DHS to identify those things in advance did not work for that rule. So I'll say on our end, I think that is exactly the intent, Heather. I think when the commissioner said we want to be more involved in rulemaking, that the intent was that we would have more kind of conversations in committees. I think we're still figuring out the logistics of that and how not to be too late in the game with that. So yeah, so Mitch, I don't know if you have thoughts. I mean, it is something for this committee. I almost wonder if, Heather, to your point, we need to start having like a little rulemaking update maybe every month. Mitch does have good news from the pharmacy board rulemaking.
Yeah, and I think like your comment specifically in there, Heather, is like everybody does this at a different pacing and rhythm. Like one of the things that I don't know that everybody here probably knows is that DOC needs to make sure that AICs have access to their rules well in advance. So they have a very different process that includes paper versions of the rules so they can make sure they get into facilities. So we're still trying to like navigate all that. The cool thing is though, is tomorrow, actually, some of you would have actually, I think all of you would have received this a couple of weeks ago when the RAC was happening, but the Board of Pharmacy is moving ahead with 2 rule changes, or it's more than that, but 2 effective rule changes, that is allowing for folks who are not opioid naive or haven't aren't naive to MOUD to get their medication resumed in pharmacies, and also to have those be bridge prescriptions, which is going to be potentially pretty big, and I imagine like parts of the state where Katie lives. So we've heard a lot of feedback too that historically there weren't feelings that the board was very like MOUD forward, and so this change has just been really cool to see them embrace, and like can't thank their leadership enough for being willing to take that on.
Thank you for answering my question. Uh, I know it's an immense amount of work because of the variation. So thank you for even trying to figure that out. I appreciate it very much.
And I'll say too, the other kind of piece to this is we are tracking all of these things. I think the bigger piece to this is like after, I think we're just now coming up on a year effectively of doing this process. And even in that, we've had to change a couple times. So we're ironing it out. And I think we're starting to build, at least for myself, I'm building that into how I even check in with agency partners. So for agency partners on the call, you'll probably have noticed the last like couple weeks, I've just started saying like any rule changes and also kind of documenting those too in a soft way. So, Katie, I know I'm first up. Do you want me to just keep going?
Yeah, because now I'm reading the newsletter and it is amazing. Like, and it caught my attention, so I was like really reading that. So yes, please. Thank you, Mitch.
Ashley, would you mind going to the next slide for me? So I just have a couple kind of preparatory slides for you. I'm gonna probably show this one slide to this committee until it's too annoying and all of you have all these boxes memorized on here. But I want to do a little bit of like here's where we came from, here's where we are today, just to kind of level set. So a couple months ago, we talked about kind of doing things in the EPIS framework, really to make sure that we are serving as this bridge between like what the community is telling us they need to implement evidence-based practices, but also like what it takes to sustain them moving forward. And so the nice thing is this gave us a really nice launch pad to talking about how we wanted to assess a lot of things about the care system itself, a lot of things about the provider system, and try to do so in a way that is helpful. Because I think the thing that we've heard during our community engagement, and I've talked with a few of you in between the last meeting where you had said like, hey, think like also I just want to give a brief shout out to Heather for thanking me for a spreadsheet. I've never had anybody thank me for a spreadsheet in my life, so it gave me a lot of joy. But if so really the hope was here is like, can we figure out what are those like inner context needs so we can actually try to address some of those systemic factors. So that's where a lot of this kind of framework of the assessment was coming from. And if you can go to the next slide for me, Ashley. So last month we met, and if you were here at the start of the meeting, you heard Judge Rigbaden and myself and a couple of people like talking about how just busy that last meeting was. We got a lot done, and what you specifically did was identified 84 different areas of interest, or at least questions of interest. And those kind of 84 questions, I was able to split across about 12 different like themes of focus. Whether those are like accurate to your intent is a very different thing, but I tried to group those as much as I could. And we met Katie, co-chair, or the co-chairs, and myself met with Tim from our Third Horizons 2 weeks ago to kind of talk about next steps. He isn't able to be here today, but one of the things that he was kind of enthusiastic about is we are exactly where we need to be for this stage of the process, and really encouraged that today we look at this as continuation of the whiteboard process. So brainstorm rules still apply. We're not wordsmithing today. We're not necessarily taking things off unless, and shout out to those of you that did this, you have feedback about like, hey, this is cumbersome because it already exists over here, or this just doesn't really like fit what maybe I recorded your thing wrong when I was typing furiously last month. Those things can be true, but otherwise, let's just keep them on the quote unquote whiteboard or on the list of questions. And then part of the next process will be working with Tim and the rest of the Third Horizons team to really pare this down to a survey that is actually going to be completed. Because I think the big fear that I have, and if any of you have filled out a long survey, is somebody opening that thing up and going, nope, I'm okay. I don't want to do this, and also acknowledging there's going to be a lot of challenge here. One of the really neat things about this committee is that you represent a very wide range of services and a very wide range of subject matter expertise across that. And being able to pull off a survey that is going to help give us some insight across all of those service areas is going to be a little bit of a challenge. So we're going to be talking through like, is this going to be a branching survey where people click on certain things, so certain options become available to them? So all that to say, the amount of questions here is helpful for this stage of the process. So please don't let that scare you and don't think we're going to pump out a survey that goes 100 questions to every single provider in the state or anything, because that would be a little scary too. Yeah, so that's kind of like where we started, where we come from. That list of questions can be found on our website. That is sorted into a couple different formats for you. One of which also is a Word document, or I think it's a PDF now, but it has also all of the strategies for the comprehensive plan. So you can kind of reflect on those a lot quicker back and forth too. And Katie, do you want me to take the next slide that was Bradley's too?
Yeah, go ahead.
Okay. Go ahead, Ashley. Cool. So today, this is really where our work is going to be kind of living, is like figuring out what areas of this are the biggest priority for you. So if there are questions that are on that list that you're like, this is really, really important to the success of the plan, that's a good thing to know. Also, if I missed any kind of if as you look at the list of questions that you came up with today and go, that is not what I meant when I said that, or that's actually not what I said when I said that, both of those things can definitely be true. Clarifying that would be really great. The other big thing that I think is really important here is giving an opportunity for you all to kind of see, like, does this align with the comprehensive plan, or is this just something that I wanted to know? And I think that that'll be a part of the prioritization effort, because a lot of this, like as I went through this list, I was sort of thinking like, yep, that would be great, that would be great, that would be great. And I think not everything do we need to know right now or for the purpose of the plan, and so that'll be a consideration. And then the last thing for us to do today is have a conversation about how are we going to get this out the door. Some of you represent, or at least one of you represents a provider organization, so you would be able to say like, I'll just send it out to all the members of this organization. Some of you have connections through other means, and so I think having a discussion a little bit on like, what is the way that we can get this out to get the maximum amount of responses, but without it feeling like we're, being overburdensome or kind of telling people too much or causing, 3 responses from one organization or something like that too. So that's kind of like what the big focus is on today. And then Katie had some cool questions for like how we might kind of structure our prioritization conversation, which I think is a good starting place. So I'll let you go ahead, Katie.
Thanks, Mitch. Thanks for calling my questions cool. So before we dive into the questions themselves, I remind everyone of the guidance we received from Tim and the work we've already done. Last month we generated a substantial list. I mean, 84 questions. When you get on the phone and they're like, "Well, stay for a brief, survey at the end of this call." I mean, how many people hang up, right? So I can't imagine like sending over 100 questions to providers, especially with how busy everybody is. So, we're going to determine which questions will provide the most meaningful information and how they support implementation of the comprehensive plan. Again, the goal isn't to build the longest survey possible, please. The goal is to gather information that has helped us understand Oregon's treatment system and how it's working. So, how should we prioritize the questions? Is there a next slide? Okay, there we go. So as we review the themes and questions, I'd encourage everyone to think less about the exact wording and more about the purpose of the question. So for each question or topic area, let's ask, can providers meaningfully answer this, or is this information available somewhere else? What type of information are we seeking? How would the answer help implement the comprehensive plan? Is the information actionable? And could this help us measure change between now and 2029? And does this require input from one provider type or multiple provider perspectives? Okay, so are we going through each question, Mitch? I'm sorry if, okay, I'm like, that's a lot of work for us to do. I mean, Heather said she did her homework, so I'm
Heather did. Honestly, like
I used the spreadsheet. Sorry, I'm talking out of turn, Mitch. I used the amazing spreadsheet because it's amazing. And I made notes on every single question because I'm anal like that.
Oh, it's great. Thank you, Heather.
and I will accept that level of detail, just for the record. But I thought a little bit about this, Katie. Because even if we screen shared the Word document, I don't think there's a really good way of looking at this like here. So in the chat, I did post a link to the document that has all of the strategies in there in the first half, and then the second half is all of the questions. I think that there's a couple ways to go about this. I think if there's any questions that immediately pop out at all of you, like we need to talk about this one, maybe that's a good way of going here. But I guess the biggest question is this a like meaningful way of prioritizing how we're looking at this on like the redraft period, or are there other questions or other kind of things that you think should be a part of the prioritization? So maybe that would be the first kind of place of reaction I'm curious about.
Heather, is your hand up or is it stale?
It's fresh.
Okay.
Thank you. I don't know, Mitch, I have some kind of high level questions. Is this okay? So I'm sorry if some of them, a couple of them might be, I have one, two, three, I have five. A couple of them might be redundant a little bit to what you've already said and what Katie's already said. So when I was going through all the questions, which are all awesome questions, that I would like to know, though some of them some of them are other places, and I've seen some stuff, but it's always good to get today's point in time. My big overarching questions as I went through there was if there's some questions I think that could be moved up, they're a little granular. So I think there's some questions that could be moved up the level to system level versus granular level, especially those that really have a direct line to our chosen implementation outcomes and goals. So that sounds like a no-brainer, but I did see there was a trend of quite a few questions that were kind of granular that would be hard for providers to answer. And then the answers would become even more granular, and that wouldn't really get us where we were going. Does that make sense? So I would say if we could go through and kind of take a look at that opportunity. There were some other trend I saw across some of the questions was making sure that the question wasn't opening up to leading people down the road of an implied promise of what our plan could do. And so I think we should be cautious of that because providers for the last 5-7 years have been asked a lot of questions that kind of imply a promise of a solution or investment or a resource that isn't really within the scope of what's the work is that's being done. And so I think we should be very cautious about that and be very clear when we send out the survey. We're asking you high level questions to look at these opportunities in the plan. And we've tried to stick to that. And then to make sure our questions really do stick to that, because there was some really great questions around like how do you, your EHR and all of these kinds of things. And I know that OHA Tech division is asking a lot of questions around this. And I kind of said the same thing to them on their survey. Well, that's great to know. That's a point in time question. What are you going to do with that information? Are you going to buy them all a system? Are you going to require every company in Oregon who delivers EHR to do something so that happens? So that's those are kind of things that run through my mind as we're looking through to analyze the questions. Is that helpful? Did that make sense? So I think that making sure that we're not having an implied promise or expansion of scope of what we're actually doing in the survey. So I think, oh, and then I did notice out of all those amazing questions, because they're all good questions, we did not say what barriers do providers have to implementing quality wait list processes and data extraction. We did not have that question. And I don't know if that would be an implied promise or not. Maybe it would. it's another question I'd like to know the answer to, whether we decide to do that kind of a question or not. Thanks.
That's a great question. It was very specific, so I feel like you were holding on to that for a little bit, Heather.
Well, I might have, it is a good question, but I do question my question. It might be too granular. It might be too granular. I mean, if there might be a better way to phrase like, oh, we're not allowed to have a wait list per such and such contract. I mean, that's a systems level barrier. And so I guess we'd have to say what systemic issues maybe, I don't know, that it would probably have to be reworded. But yeah, I'm happy to, that's why I saved it for last. Thank you, Katie.
Yeah, no, especially with all the focus on network adequacy and, focus on those wait lists. I think that's super relevant and important right now. So, Christy, go ahead.
Hi, thanks. I'm just wondering on some of the client-specific questions, if we're going to get accurate data from providers as to what clients' needs are. Sometimes we think that it's this and it's really not. So I just wonder about, those client, like, what's your biggest barrier? There were several in here about clients. So, I mean, maybe they're good questions to ask, but we might want to take the answers with a grain of salt. Because it might not actually be what the clients would say, I think.
I agree, especially if it's youth specific, right? I think that's very common with youth specific stuff. So absolutely. Thank you, Christy. So going off of what Heather had mentioned, right? So let's talk about, or who has some ideas on how do we decide what is too granular or too high level? How do we decide that?
That's a really good question, Kate, that I don't know the answer to. I'll just say right up front.
Go ahead, Heather. Go ahead, Heather. You're okay.
Okay. Yeah, it is a really good question. That's hard. I mean, I'm happy to take some time and I did send some of that to Mitch already around my thoughts around that. And I don't know if our consultant can kind of, with the guidance that we give, that it be system level and attached to our plan implementation goals and activities. If they can kind of clean up the list a little bit and then we can take a look at it, I would be happy to be, even if that's a subcommittee, I would be happy to do that. I don't know if that's an option to ponder. And then I think like one of the things I would come back, an example I would give that I'd come back to this group on is there's a whole bunch of questions on culturally specific, culturally responsive, and co-occurring along with the EHR questions that we're asking folks for a narrative, a qualitative narrative probably, but that also doesn't give us super clear systemic information beyond knowing, we can mention the team could poll who has CLSS and who has co-occurring certification from the licensing division. And we know that they're validated to a standard, but everybody else who tells us something, all it tells us is they believe they do something, which is valid and real, but that's what it tells us. It could be quite variable. So I guess a question to the group is, do we want to count that? And if we do count that, I think that's cool, but we got to say, hey, these we know are validated at this point in time, and these we know are potentials, but not validated at this point in time. And I'm okay with that kind of systemic data, but sometimes our habit is then to say, oh, let's ask the provider what tools they use and why do they think that? And I don't know if at this point in time that would be too granular. That's kind of my example to talk about how to narrow the choices a little bit? Is that helpful? Does that make sense?
Yeah, and I just want to make sure I'm capturing something that I'm not sure if you meant this or if you implied this, Heather, but it almost feels like for some of these questions, like where we have an existing comparison point, like whether it's license certification related like figures or something, like also grounding those and like here's what we know structurally versus like here's what our responses said, and being
Yeah.
able to share those is going to be important.
Yeah, we did something really cool with AOCMHP led crisis stabilization group, because we have formal crisis stabilization through the CMHP contracts. And then we also have many providers who run that crisis stabilization. To the consumer, it wouldn't look any different, but it's funded through a different pathway, meets a different set of criteria. And so we did an inventory of both, and that was very useful. We didn't go into deep detail and ask a lot of time from those informal programs, which people would then call formal programs like Cahoots, but they're not part of that formal CMHP process. So I think we could do the similar kind of thing with CLSS and co-occurring. Does that make sense, Mitch, what I'm saying? Yeah. And just to be cautious that our excitement of gathering, because I am a data nerd and I would ask people like 300 questions, because I'm nosy and I want to know, but to try to avoid that as much as we can. So, and then I saw, and then on the value, I think there's other places we can get data too. Like we do a workforce survey here at OCBH. And so we actually have some questions. We asked questions that were actually on this list for that workforce survey, and we do that annually. As I mentioned, Health IT is asking a whole bunch of questions and developing a survey for providers on EHR. So yeah, I think there's, as you're a great sleuth, Mitch, and you're getting all kinds of information and bringing it to us. So I know you do a great job with that. So making sure we do that too, that if we really want the answer to something, it might be somewhere.
I don't know that I've ever been called a sleuth before, but I kind of want like my own like
You
Hardy
are.
Boys book
You
now.
are well, most sleuths are data geeks. We like the details. At least that's what I think.
Heather, I totally agree with you, and kind of what you were saying along the lines of like what questions can be meaningfully answered by providers, or is the information somewhere else, right? Kind of like the CLSS, the class stuff, right? We can find that somewhere else. We don't need to be asking them when it's already out there. So thank you for pointing that out.
And like that section that you were talking about, Heather, there's a block of questions from 30 to 36 that probably are all in your survey, the wage survey and analysis.
Oh my gosh, you read my spreadsheet. You must be able to
I
spy
did.
my
I'm reading
computer.
it. See, I'm on it.
Yeah, because we absolutely don't want to be duplicating these things as well, right? Because nothing is more irritating when you're, asked the same questions over and over again. So wouldn't it be funny if we like cross-reference them and see if the answers change though? No, I'm just kidding.
No,
I
actually,
am.
that would be hilarious and I would enjoy it thoroughly, but I would be in so much trouble.
I I am realizing something that, and also one thing I'll throw out too, I can paste these questions in the chat if folks want like not to have a slide and for us to see each other if that's helpful for discussion. Just let me know about that. But to Heather, your member list probably better than anybody else on this call. Is there anybody that we would be missing out on in our like going back to that conversation about like the folks that y'all represent make up like a huge service continuum, a bunch of different provider things, like who would we be missing if we excised question 30 through 36 as Christy had
Oh
suggested?
yeah, you would,
Would
of
that still
course,
impact physical
yeah,
health, so on and so forth?
of course you would be missing. Our members are uh, have COAs. We have over 60 agencies that are members, and there's probably about 140 to 180. I haven't looked at the list lately. I don't know if anybody from licensing is here. Agencies who hold close to 400 COAs because, most agencies have more than one COA. So the amount of COAs is not agencies, it's program, just so people know that. So the actual amount of agencies is much smaller. It's like 120 to 180 or something like that. So we have 60 of those agencies. So of course, and then there are some COAs like Dewey programs where it's one person and they have a COA and they do a small Dewey program or a private practice or something, or the group practice, maybe there's 5 of them. So we have some small, our smallest member is like 7 to 10 employees. But yeah, of course but it is a broad swath because we do have all the service elements represented. We do have all the different sizes, and we have folks in every geographic region, except for like three counties or something silly like that, across the state. So it's a pretty good swath of folks. If we can get everyone to answer.
And it's strictly behavioral health providers, right?
We also have peer-run organizations.
Okay.
So we have peer-run organizations, behavioral health providers. Some of those have FQs. Some of those are CCBHCs. Some of those have a FQ and a CCBHC and maybe more than one CMHP contract. So yeah, it's all the flavors. Yeah.
That was so many acronyms in one sentence. Like, bravo, Heather.
Oh, I've been doing this for 30 years. I can roll the acronyms like you wouldn't believe. Okay, I'll say that. Certified Community Behavioral Health Centers, community mental health programs, federally qualified health centers, and every other service element because, an agency can run, multiple service lines and contracts, and they do to be sustainable.
Absolutely. I think because we also, towards the end of our conversation last month, we were talking about physical health because there are physical health providers, especially in those rural and frontier communities, that do provide not necessarily like SUD or mental health treatment, but they do provide, MOUD. And so I think like what Mitch was asking, those questions, if we eliminated them, would we still need to ask like those physical health providers that are a part of the continuum? Is I guess a question for everybody, or I guess I'm not sure.
I was actually wondering, could we pick on, I see Beth, you're on camera. How much do you, and I'll grab what these specific questions are, but staffing shortages, burnouts, positions that are hard to recruit and retain, how prepared new staff are, like how much do you think that is reflective of what behavioral health has versus maybe is radically different?
Well, sorry, I'm going to not answer your question, but I think I'm like a little bit I was focused on this like list of how do we prioritize questions, the last bullet, which is also sort of relevant here, and going back to like what the intention is. And I think a lot of the like in terms of narrowing it down, a lot of these questions, which is also sort of to your point, it would need to be they would need to be like a leader of an organization rather than a direct care provider. And so one way to narrow down could be to just remove the questions that would need to be a direct care provider. Like I'm looking at, are youth specific services sufficient in your region? A person who's like a primary care provider in clinic day in and day out has an opinion, but won't necessarily know objectively. That might be a bad example, but so sorry, that doesn't answer your question, but is an idea.
Not believe you didn't answer my question perfectly for a thing that we're doing for kind of the first time. No, it's great though.
I think also just when we look at these questions, like what would knowing this change what we do? The answer to the questions, like would it change how we move through the comprehensive plan and make decisions on that based on the answer that we get from those questions, right? Just really thinking about the meaningfulness, that's a word, behind it, and would it change what we do, and how would this information help us make decisions? I'm gonna guess everybody's looking at the questions and going through them. Is that a good assumption?
Something I'm super curious about all of your, I guess, perspectives on this is a big piece of this is repeatability. Are there any questions or things that we talked about last month that 4 years, like if we asked it again, it's just not a good idea. Like we wouldn't have, it's not as possible to make a change, or like we like it would just be a reminder of the thing we didn't do, didn't do. So is there like that would be another kind of framing here. Go ahead, Heather.
Yeah, I do think not to harp on the EHR questions, but I think that's one area that definitely hits that spot. There was a variety of questions that I listed out that are related to referral workflows and tracking data analysis of referral workflows. And they're perhaps pretty granular and have been asked many, many times by OCBH, by OHA, by special work groups, by all kinds of folks. And so our members have attended many settings where they've responded to those questions. So, like, I could feel pretty confident in giving ADPC a summary of those experiences and responses over the last, we've been around since 2019, and they haven't really changed, to be honest, because we do ask them periodically. I could give a summary of those responses. And our membership has changed. Like in 2019, we had 22 members. We now have over 60, and the responses are basically the same. So that's, if people were comfortable, that's something to do, or if that's an area to kind of think about. And I know there's projects in the works trying to work on that. And I know there's a little bit of that in our plan. So I think that's a way we could probably inform that in a good enough manner to get to support that work. I don't know. That's just my opinion. Like it feels like to me we have folks involved in operating that, even that when we got to that stage of the implementation, we could even bring them in to talk about stuff. Maybe. I don't know.
Anybody else? What do others think? Going on with the conversation and discussion. There any thoughts?
Should I pick on Art or Katrin in this next moment? Because both of you, I like how Art's like, oh gosh, no. I both of you were like, I think really instrumental at driving a bunch of those questions last time. And part of that I think is you're very close to the work. And one of the things I'm really curious about, we heard over community engagement that there was this feeling that when changes happened, we didn't bring our workforce with them, or we didn't kind of like help with that readiness for implementation of these. And theoretically, a new if we had timelier access or transitions to care that are different or different evidence-based practices, we would need to be planning for how to like help people along. Thinking on the questions, is there anything that is missing, or does this give us a pretty good viewpoint of like what technical assistance would need to be available or is lacking currently? Because that's another thing that I don't want to lose sight of as part of the implementation of the plan.
I don't really feel like anything's missing.
Yeah, I don't feel like there's anything missing. And I agree with everything that's been said as far as filtering things. I guess for me, it's easy to see what I see every day as challenges and barriers. It's harder to find out who plays a part in what is the question and who's answering it when there's so many different governing bodies in different areas. An example, and I think this coincides with what Heather talked about, we did try a system before. It was OWITS back in the day, right? And we used to call it OSHITS because that was a state stab at the EHR system when the ATR grant had came out. Um, but yeah, I think this is really thorough and yeah.
Oh, Art, you took me back. Took me back. Remember that treatment plan didn't connect to the notes. It was great. So I
It was even funnier when we got a site review from the state and they hit their own assessment that they created in OWITS. Yeah.
yeah. Sorry. That was funny.
Great that we have historians on the committee. It's a helpful thing. I always like I said, I always like when I get to drop that I use carbon copy forms for state reporting, you know.
Are we able to grab some of the answers here out of what's it called now? Again, history. It used to be called CPMS. What's it? It's roads now. Orchards, roads.
Yeah, so that's a good question. Is it for, because I think this kind of goes with similar to what Heather said of like, are there selections of this that we just want to say, like, for example, we cross-reference for license certification, and then maybe for other questions that are in here, we just have this be a kind of, I would say, an appendix of the report of like roads data showed this about the client populations or something, and that kind of maybe addresses some of the granularity that you were speaking to also.
And then if we're going to be asking like physical health places like at OHSU, where Bradley and Beth work out, I think, are we gonna create a couple, like two different ones for those physical health? We might have answered this already, but there's some things I know that from conversations, there is some frustration when it comes to like ASAM requirements and their limitations on what they can and cannot provide, or because there might not be a COA, especially when it comes to hospitals, right? And so we are going to create two of those because I think ensuring that input from those specific providers is super important when it comes to this work because they do such great work. Like I said, even in rural and frontier where you have those smaller communities, and they're providing a lot of the work. So we understand that continuum. I just a clarifying question, I guess. Or is there going to be like different? We're going to pull out some of these questions. Okay, great.
Yeah, so it's a yes and for this one. So not over promising for anything, but Tim had mentioned one of his staff is looking at kind of where branching could occur in this. So I think it's very possible that there will just be and it like seemingly an entirely different survey that one provider gets that another didn't because they answered yes to a very particular question. And I think that that also gives the ability for us to not in 2029 administer this again and go, wait, why is all of this different? And it's because we're comparing our physical health to an outpatient behavioral health program. So that should be captured. I guess the question that maybe would be helpful is like, do folks have any thoughts or concerns or ideas about like where those like where things become too different or too similar? Like, is a withdrawal management program similar enough to a residential program that they exist in that same branch, or not? Like those are, and then that might be a thing that we have to figure out down the road, but it might just be worth asking as like a brief conversation piece today.
So on the survey, are you guys thinking of identifying who the provider is that's answering? So what you're saying, Mitch, is you would be able to identify, is this a primary care versus an actual COA residential level? Okay.
Yeah. And identifying who it is and who filled it out, because I think, and make, yeah, because that will make a big difference, as Beth said, for sure.
How anonymous do these do? Is there any anonymity that is like needed in this, or do you think like name of organization, name of like that would all be like very okay then? Okay.
Especially if I think if the questions are high level enough. I didn't see questions here that were intimate in a way that would make people nervous, but I could always be wrong. There'll always be somebody who disagrees with me, but I think overall, I think you're pretty good. And I think that will help make sure you have good data. And you can even say that, we didn't do anonymous because it's really important to us that your agency fills it out once and we know what setting you are because of all the differences, blah, blah, blah.
I don't know if this matters, but when I think of positions as a director, I don't believe you have to have clinical certifications. Someone could just have a master's, degree. So I know directors that, and even medical directors that know a lot about physical stuff and they have no understanding of the clinical piece of the groups and whatnot in some settings, especially outpatient, since it's not residential or detox. They just need it for the COA. So they may not be as involved or able to answer these questions as in depth as a medical director of a 24-hour care facility.
So that kind of poses a challenge for like us saying like have this person specifically fill it out in your organization, but instead like a direction would be like have somebody who can speak to all of these things regardless, or like what kind of where's that going?
Could we break it into sections that said like maybe administrative level and then maybe at the clinical supervisor level? I mean, I don't want to do 37 surveys, but it's a really good point that, a lot of program directors don't have a clue what's going on with the actual clients. Yeah, I never thought of it about it.
Go ahead, Heather.
What we do for the workforce survey, how we approach this is we send it to a identified point person who is either the executive director or their designated person that likes to receive the surveys. And then we give them instruction that you may not be able to fill these out. Please consult your leadership team. And that seems to work pretty well. That seems to work pretty well for folks because everybody's structure is so different depending on their size and how lean their administrative staffing, well, depending on how lean their staffing is, period. So, lots of people are doing multiple jobs. So that's the direction we give to folks to give them the flexibility they need so that we can get the best data we can get, along with keeping the questions high level so that they don't have to dive too deep into their staff for granular information.
Can you repeat that? You tell them that there's questions that they may not be able to answer. I'm sorry, say that again.
We ensure in our process, because we've been doing this for about 6 years now, we ensure in our process that we have a point person to send the survey to. And then when we give the survey to the point person, there's an introduction where it says, thank you for filling out the survey. As you're reviewing the questions, you may need to consult other leaders on your team to fulfill the answers, to get the most accurate information as possible. We really appreciate your time and input into the survey. And yeah, that's that. We keep it that simple, just to be clear, just to give them permission to do what they need to do, to fill out the survey. And then, in this case, we'd probably want to point out that this is about systemic level, systems level change and impacts. And we've tried to ensure that that you don't have to go too granular and to make the answers. But I'm sure the consultant can craft the drop down boxes and the narrative boxes in a way that kind of can guide that process. So we try to do that too. So we worked with our handful of leaders in a couple, because it's a workforce survey. So we worked with the HR folks and the CEOs and some clinical directors to actually craft the questions so that we would do exactly what we're talking about here, that the questions were appropriate to the data we were really trying to get, and that we weren't being overly granular, so that we could really understand important systemic trends to get the right information to understand those trends. So, and it's the same process we're doing here, really, to kind of workshop the questions. And I'm happy to take, if this group wanted, sorry, Katrin, Allison's not here, but if we wanted to take it to like clinical directors or somebody else, I mean, I'm happy to see if I can get some volunteers to look at it too from this point. I'm sure Beth has folks too, from the different service. Anyway, there's ways we could approach that. But I know the consultant has tons of experience doing this too, which is super helpful.
Yeah. Thank you, Heather, for repeating that for me. I had to process that. I had to wrap my mind around it, because I guess I never thought about it in a way where if I were to send it out, right, to all 12 counties, it would include clinical supervisors, it would include peers, it would, include all, individuals that are doing direct line care, not necessarily just medical or the clinical directors or CEOs and stuff like that. So like one agency, right, one CMHP would answer at one time, but it be from multiple staff that would be able to answer it confidently. I never thought about it like that. So thank you for that.
It's been a learning process. Happy to share. I took enough psychology research to get myself in trouble.
Because then you might end up with like 10 answers from one CMHP and like 2 answers from like another. Yeah, no, that checks out. Okay.
Yeah, that happens. Yeah.
Yes.
Definitely the same answer and not conflicting at all, I'm sure.
See, it might have that too, right? Then we really don't know what's going on out there. Absolutely. I know we still have about 20 minutes-ish. I mean, are folks feeling pretty happy about, the direction that we're going with this? Questions answered, concerns, or if there's any concerns that they've been answered, any lingering thoughts? Sorry, I was reading your chat, Mitch. Because if not, I mean, we can end early. Oh, never mind. Go ahead, Mitch. I forgot we had another slide. Go ahead.
No. I wasn't saying anything.
I was just trying to move, like if the committee's feeling pretty good about where we're at with this, and nobody else has any additional thoughts or questions about questions, then we can totally move on and we can end a little bit early for you guys.
saw Heather called me out in the chat. Thanks a lot for that. No, something I just haven't found the right time to like jump in and say, and maybe it's really cynical of me, but I do think that one thing that we'll need to make sure we're really mindful about is the time commitment of the survey and like making it as user friendly as possible. And like I get that open response questions can be really informative, but the likelihood of people actually filling out open response questions are very, low. And something that I personally, as a clinical director, always find super ironic is when I receive some sort of a survey like this that's asking me about my primary concerns. I say that my primary concerns are administrative burden. And then the solution is to take this like 3 hour long survey that nobody's going to do anything with anyway. And again, that's super cynical, but I do think that we should I've seen the thing in the chat box, like what are some ways that we can increase participation as well as make it doable as opposed to like more punishment.
I really appreciate that comment very much. I'm Moxie. I wonder if there's some way that we could, in the introduction to the survey, tell people what we did with the results of the last survey, like how that's impacted the course of treatment and the network in the state and the funding and enforcement of quality measures and administrative rules and things like that. Just because if people can see how it was applied in the past and that this is an effective body of people that are gathering the information, I think it will motivate people to really think about it more. And the only other thought I have on that kind of general area with surveys is that it seems to help a lot to have pretty specific questions with answers that are really well thought out so that you can choose more than one answer if that would be useful, or if you're really looking for the very most important thing, that will come out. And then the last question, if you can just ask, is there anything else that you want to share that we haven't asked about? Because sometimes people fill out a survey with some burning desire to share one thing and then it's not in there. But a lot of open-ended questions, I would agree, people will just be tired and not put as much time into it. Or they might write something that you don't really understand and you might not have the chance to ever ask them about it. So.
1000% to all of this. And I'm also realizing when I mentioned all of the cool bridging things, bridging question process that Tim was going to do, I forgot to mention the other stuff that we talked about, which is they are looking at how many of these questions can be Likert scales, multiple choice, specific choice, to be able to set like an example of this rather than have people go like, which licenses do you hold in a big box? We can just supply the dang list of which licenses the state allows you to have, and then you can just click those things, for example,
And on the license question, Mitch, like we pull that from public records. And so, because we use it, I'll just be honest, we use it to do recruitment for membership for OCBH. So we pull it all the time. And so you can see everybody, all the COAs, all the different licenses through OHA and ODHS. And you don't even have to ask people that.
I'm almost imagining then that so one process of prioritization that I feel like we're talking around, but to just name it directly is there should be a process of removing questions that we can just answer through an existing data set, whether it's like a licensing list or something. Like if we can answer it there, we shouldn't maybe ask it there to them. Go ahead, Beth.
I also wonder, it's probably too late for this, but considering like limiting to X number of questions that seem like reasonable as a time commitment ask, and then following up with some qualitative interviews, as opposed to just like blanket trying to survey everybody and getting fewer responses rather than like in-depth, actually really rich responses from targeted qualitative interviews that maybe we could maybe not incentivize, but at least like through relationships, ask favors. And also, I mean, AI can like qualitative, I know it's a little tricky with yeah, anyway, like ethically, but AI analysis of qualitative interviews is like pretty valid these days.
I just want to throw in that I agree, Beth, because I think we overlook or if we forget about qualitative data sometimes, and or we don't think it holds as much weight as it should, right? So I just wanted to say that I agree.
I saw Katie posted the link for the current prevention survey. Please don't fill that out if you're not in prevention, by the way. But
I was just an example. I was
no,
just
no,
throwing
no,
it there
no.
to look at what
Yeah.
they've done already.
No, and they'll honestly kick that stuff out. The thing that it also that Tim's team did that I didn't know about until pretty recently that I think is really cool is they created a document because again, there will be a point in this when all of you are going to be instrumental in getting this thing out the door and responded to. And one of the things they put together was a list of like talking points and like things that you could use to explain this to other people too. So you don't need to feel like you're a survey expert, but you'll be able to say like, here's why, here's what this is doing, and so on and so forth. Go ahead, Moxie.
It comes up occasionally that there are groups of people who, for whom quantitative data don't really capture their experience very well, or their concerns may kind of blend in with general population data. So things like overdose data or prevalence data. This came up the other day in our commissioner meeting. Julia Mines had some really good suggestions about it. I just wonder if there's some way of making sure that we're doing qualitative research with minoritized groups, ethnic and gender identity and sexual orientation. Just because sometimes they can tell you why the survey didn't really apply to them very well. And that can be the most rich conversation. Thanks.
Thank you for highlighting that. And I think that that definitely is a layer of complexity that I do trust Third Horizons with helping us navigate. It is a challenge. When I was at the ETDC, we had like a storytelling review process for our tribal clinical supervision work because like that was just the most effective way of getting information. So I definitely hear what you're saying. Any other thoughts about prioritization before we start editing this list and trying to unopen-end some of these questions? I know Katie had already mentioned it. Should we go to public comment if we have any and then give folks like a 15 minutes to, I guess, I don't know if it's the same near you, but go out in the clouds. I was gonna say go out in the sun, go out in the clouds.
It's sunny here.
Go out in whatever weather is around you.
And I have not received any written public comment or anything like that.
Well, with that, then I guess enjoy your 15 minutes whenever weather you have.